Welcome to Health System CIO's interview with Steven Ramirez, Vice President and Chief Information Security Officer with Renown Health. I'm Anthony Guerra, founder and editor-in-chief. Steve, thanks for joining me.
Glad to be here.
All right, very good. Do you want to start off, tell me about a little bit about your organization and your role?
Yes, my name's Steven Ramirez again, and I'm the Vice President and Chief Information Security Officer at Renown Health. I've been at Renown for about 10 months now, today actually. It is a system up in Reno, Nevada. It's the area trauma center. So any of you bad skiers that have been out there, definitely come see us. So it does have a dedicated children cancer center and a new affiliation with University of Nevada, Reno, UNR. So that partnership is really going to enable us to start getting cutting edge research, innovation, et cetera. And they have been the biggest player in the market for quite some time, serving Northern Nevada for quite a while. So.
Very good. Can you tell us a little bit about your career journey? I like to find out how CISOs in healthcare wound up where they are.
Yes, it actually started up at Georgetown, up in Washington, D.C. And right as a lot of the digital transformation components were going on, I was the quote millennial. So they threw a lot of the IT risk management and some of that at me since I had the only Facebook account in the office. And the rest was history. Went from there on to CHI, right as CHI was really in acquisition mode. CHI is now Common Spirit, so was part of the merger and acquisition team. So really saw that footprint grow to 19 states, over 100 hospitals into what it is today with Common Spirit and that merger with Dignity. Then went over to a short stint at Baptist Health in Louisville, Kentucky, and then went to the vendor side. So got to see what the other side of the aisle was doing, really encompassing payer and provider. Worked at McKesson on the medical imaging side, so got to do a lot of IT risk management, cybersecurity advisory work, also looking at continuity and redundancy for medical imaging system. And that's really where a lot of the medical imaging security really was starting to come to the forefront associated with that. And then went on to IBM on the Watson Health side, working on the Medicare, Medicaid side, and was a appointed CMS security officer as part of that. So got to go through and do that whole fun stuff on the NIST 853 and going through the ARS controls that CMS has, as well as the ATO, the authority to operate on, onboarding any of their systems. So really has helped me get a strong background into that. I then went over to U of L Health, right as they were doing an acquisition of Jewish in that system in the Louisville, Kentucky market. So that was about 15,000 employees, 9 sites here in the Louisville, Kentucky area. And then came to join Chuck out in Renown. So really through and through on healthcare. Both my parents are providers, so like to say from cradle to hopefully a future down the straight grave, been in healthcare through and through. So yeah, there's the story of me.
And for those who may not be aware, Chuck is Chuck Podesta, who I mentioned is a good friend of mine, and now you're working with him. So we'll get more into that a little more later in the interview. Well, when I looked at your LinkedIn profile, you talked about your career path. I noticed a number of those positions had a strong emphasis on business continuity planning and disaster recovery. To me, that is one of the most important areas right now where CISOs have to be playing, focusing, and spending their time. So what do you think are a couple of the keys to getting that right and the right way to approach that for CISOs?
Yeah, that was great on really, because you're planning for the worst case or the what ifs with a lot of that. So that was, enabled me to really work backwards that, we're looking at these critical process assets, technologies, people process technology, a lot of stuff that we do look at from a CISO perspective associated with that. So I think that is critical. We've seen, especially with healthcare, that it's almost seems like every other week that there's another health system being impacted by that. And really that puts the emphasis on, we're so dependent on IT systems as a health system, as a healthcare community, that we do have to have that cyber resilience state of mind, that if our systems go down, how are we able to get them back up as quickly as possible, but also maintain operations? Just because there's an impact to IT, we can't say, sorry guys, we're closing, being a healthcare provider. So really, having to ensure that we are providing quality, safe care through the full life cycle of a patient being, at our facility. So again, that really is critical. And I think it is still a shortfall in healthcare in general, making sure that people do that, especially with a lot of our new nursing students, travel nurses, et cetera, coming in, that a lot of people aren't used to downtime. So if you have to go into paper and, look at a lot of that, that's why we're seeing the impact of ransomware and whatnot being so impactful to organizations, just because of, people being so dependent on technology and never having to do it the old fashioned way.
What do you have to do as a CISO? I mean, it seems to me you have to think at a high level about, the well-being and the operations, as you said, over the organization. You can't just get to the end of your defined job and stop, because then you're never going to help the clinical side figure out what they have to do. And it's tricky because it's not really your job to tell the clinicians to make sure they know how to go to paper. But from my discussions, it seems like there is no one sitting above, unless this is going to be driven by a CEO or a COO, or a chief administrative officer, someone who sits above everything and can say, hey guys, we all have to figure this out. Let's make a committee. So, but what is the CISO's role? If there's nobody above driving this, should they drive it? And how can they drive it without sort of stepping on toes and people saying, hey, whoa, go play in IT and stop bothering me?
But you do hit a good point, that a lot of BCDR, just because of the technology aspect, everybody thinks IT owns it, but IT can really only do so much. And that's really where the CISO job has also evolved into, a lot of the points you said on needing to really be embedded into the business and clinical side of the house, because that's where you really would see the biggest impacts if there was a system interruption. But it's internal relationship building and partnership that I have a close relationship with our chief compliance officer, because that gets into compliance related issues and they need to help drive that aspect. Also your CMIO, big stakeholder, and really ensuring the success of that. So that's been a focal point that we put into our GRC, which is Governance, Risk and Compliance Committee, that then filters through our Audit and Compliance Committee, that then goes up through the board. So we're trying to get that level of visibility, to really tell that story, that a lot of these organizations that have been hit by ransomware, you can invest a lot into technology, people, and your overall cyber program, but it's just a matter of time that somebody clicks the wrong link, etc., that you're going to be in that situation. With our focus in IT being able to recover, but then how can we partner with the business to have that really work in that area of ensuring operational continuity. So that's where that the buzzword cyber resilience has really come into play, that we know the tornadoes, the old-fashioned emergency management, but really using that same mindset of like a Hurricane Katrina and the impact operationally on a hospital, but to embed that cyber set of mind. So that's really doing tabletops, getting with those clinical stakeholders, but then really making sure that it is built into the culture of the organization, but also having those key stakeholders, like you said, from the top down, that a lot of those players are members of the committee, the board's interested in this. Obviously, again, as I said, making sure that we get the technology up and running as quickly as possible is, really a focus of the IT side, but also really making sure that we can continue patient care, and that's training awareness, and then seeing, working with the clinical teams to see what potential single points of failure there are, and practicing test and repeat like they do from, in the ED if there's a chemical spill or a mass casualty incident. So using that same mindset of emergency management into cyber preparedness.
So if you were giving a message to your CISO colleagues and saying, hey, you have to be initiating these conversations with for example, your CMIO, you have to be discussing with them and say, hey, let me take you through a scenario. I just want to talk about it. We have a ransomware event. We have to shut down these applications. This is something that could happen. You need to know what to do when I call you and say these systems are coming offline in 30 minutes. Like, I can't figure that out for you, but I want to initiate this conversation so you understand how this will go down from our end, and then you can figure out your end. Would you say you have to be doing that as a CISO?
Yes, you're almost serving as the traffic cop / moderator to bring those discussions to those stakeholders, as you said, to really make it the onus on that we can't do everything for them. For example, clinical or medical imaging, that if there's, a downtime to the PACS systems, you can still walk up to the modalities, the physical devices themselves. But, maybe if a provider doesn't know that, based on where they're located, if it's a remote read, et cetera, like small things like that, on having a plan, executing them, making sure people are able to communicate, in situations like that. That's not necessarily IT's job, but that's really on partnering with your CMIO, your radiology chiefs, and those to really ensure that that department looks at that, and really looking at everything from a work stream and those interconnections, interdependencies, starting at the emergency department to the critical care units and all of that, to see who those key stakeholders, to all of them, to really put that ecosystem together, then enables you to work with those teams to see how those handoffs are, because things can be done. We've seen hospitals operate on downtime. They do on planned downtime all the time. So it's really about, just making sure you look for those gaps, wash and repeat on training. And again, having those discussions, facilitating those with those, key stakeholders in the system.
I want, it's a great plan. It's a great idea. And I wonder if you're not getting the engagement that you think you need in these conversations. You initiate these conversations, let's say you're just not getting the engagement, you're not seeing things move forward. That would be concerning. I would imagine that's a case where you want to just make sure things are documented, because after the fact, you want to be able to say, I tried.
No, 100%.
Yeah.
Yeah, and that's the best way. That's where audit and compliance are your best friends, because again, I always use that as a targeted way to bring something, up to the board visibility. I can say all day that this is a risk, et cetera, tying it to cybersecurity. But then if it becomes a regulatory, a compliance, an accreditation, or a potential, we could be sued because we're negligent and not having aspects of this together, our cyber insurance group isn't going to cover us, et cetera. That there's a lot of ways that you can have those discussions with them to help garner that discussion with those groups. Because hearing it from, just the CISO alone, but then hearing it from another, key leader like your compliance officer really helps build that and drive that within the organization.
It's interesting. You mentioned your parents are providers. Are they physicians, nurses?
My mom's a respiratory therapist,
Uh-huh.
and my dad was a primary care emergency department provider. So he's actually the doctor and the
Yeah.
boots on the ground from a clinical side.
So that's very interesting. I'm sure it gives you, you have a understanding of clinical care, the challenges that go on with clinical care, that no matter how much another CISO will spend time in the hospital, you've sort of got a leg up on them with understanding. My wife's a nurse practitioner, and just through her stories, I understand a little bit more about the clinical environment, certainly than I would have if I hadn't been married to her, because I just, other than when I've gone to the hospital in the ER or something, I didn't see what's going on. It helps you understand, I guess, how complicated it is and how busy they are. I mean, there aren't hours or half hours of open time where they can attend a committee meeting, right? So when you want to get that engagement, when you want their time, you understand how much you're asking them, correct?
Correct. Yeah, and I've seen that, really growing up in the office, seeing my dad run around, or even if I'm, in town and see him and I'm trying to take him a sandwich for lunch, if he's running in between and, badging in and out, using those kind of different technologies. He's always been a great resource, because again, I've seen it firsthand, talked about his woes, and he still invites me to dinner now that I'm in the IT side. So, but he has always been a great resource to be like, Dad, like, what do you think of this? Or is this really something that's that impactful? To really have that. So it's, and I always tell my CMIO that, so I think it's a good kind of icebreaker to say that, I can't do what you do, but I understand a lot of it, having grown up and seeing, components of that, to really make it real when I'm talking to her, in our case, at our current organization, or CMIOs in my past, or other clinical leaders.
Right. So even saying, Dad, what's the best way? I need the physicians to do this, or I need the physicians to stop doing that. What's the best way to engage with them? He probably gives you great advice.
Yes.
It basically says, leave them alone.
Yes. Make it work. Make it
Make
work.
make it work and leave them alone and don't disrupt their workflow, right?
Yes. Yes. We know clicks are precious gold on the clinical side. So
Right, right. Very good. A high level question. What are one or two of the big trends you're looking at that you think other CISOs should be aware of, thinking about, maybe preparing their organizations to deal with?
I think identity access management still huge and still a big gap in the industry. And it's just because healthcare is so complex, that we have community connect providers, we have community providers, we just have such a big end user base that people that need to access our systems, especially being trauma hospitals or research affiliated, there's just a wealth of data and a need for people to be able to access, especially with also legislation of information blocking. Like, people understand that patients need to be able to have their information when they want it, when they need it, but that's going to also open up a work stream of scammers in a sense that they're going to, spoof being, Steven Ramirez wants to have an access to his record to see XYZ, and there's a potential for holding someone else's data. I've seen some articles on that they'll say, okay, we're holding Steven's data hostage. We have all of that information and maybe we'll leak it if it's, based on your role or who you are. So it's always, with any new technology, new legislation, a lot of times people don't think of the downstream security impact. I know that's a subset of identity access management, but that's also getting into that zero trust model for not only people that are accessing our systems, but information we're sharing out. Like, how do we authenticate? How do we ensure that we're actually giving it to people who they say they are? And that, then potentially provides an administrative burden. If we're, it's tough to get a lot of our patients to do two-factor authentication just for my chart. So as you can imagine, if they're coming in and requesting a record. But again, as we've seen, ransomware is always related to access. A lot of that is, this admin account wasn't two-factored, or this hadn't, as a domain admin account and it shouldn't have been, or this person left the organization 30 days ago, or it was a managed service provider. So a lot of things that we should be doing as part of Security 101 before we're getting these new buzzwords like zero trust. I think focusing on those fundamentals. There's still organizations that don't two-factor. We should be doing some of those as a baseline, but also early detection. As I said earlier, it's inevitable that, a lot of organizations are going to experience a security event at some point in their tenure. It's something that, keep us CISOs up at night. So we don't generally sleep anyway, but really on focusing on that I like to use the healthcare model, since being in healthcare, that early detection, like primary care, the earlier we can detect something like your doctor would, the earlier we can stop the spread. So using that hygiene methodology for medicine into cybersecurity is a way you can help not only educate your clinical staff, but also really preach that message internally. So I've really made a focus on 10 to 15 minute detection times, with containment, and then, being able to have that seamless incident response, because stopping the spread, stopping the impact is really how we can really have a, more seamless and expedited recovery versus, all systems are off, we're out for multiple weeks. So that's really been the key. Access and early detection, have really been my biggest focal points.
Very good, very good. So let's talk a little bit more about IAM. It's not easy, right? It's not just buying a product and you cut the check and we're good. We have identity and access management. Tell me what's the rub? What's the hard part about it?
It's just so complex in healthcare because you've got all of the internal. So, the nurses that are charting, your pharmacist doing the medication, your radiologist, they all need very different system access. And then, with interoperability, making sure these systems talk, and they're doing 100 things at once, as we know with COVID, and even before that there was staffing shortages. So that's where we're seeing why phishing still is so prevalent and effective, that if an account like that's compromised, look at the wealth of information and or system access they can have. But then you take that a step further, getting into IoT medical devices. That's people that have generally privileged access to be able to go onboard, offboard systems. And of course, the IT administrators that also have that privileged access to keep the lights on. And then you have external access for vendors that might be monitoring, hosted systems or maintaining their systems, community partners. So as you can imagine, just, these 5 or 6 different use cases and or users that we're looking at, that gets really complex on level of access, system level access, data level access, that it just makes it very complex in tracking a lot of that. And it just also makes that attack surface so big as a healthcare organization on what they're able to do, that we've seen compromised just basic user accounts before, that people are trying to go run scripts to, inject you with malware, ransomware, et cetera, on like a Citrix hosted server. So it's already a, monumental and Herculean effort to manage all of those assets and access internally, but then you throw in the external need, from a research perspective, a community provider wanting to, refer you and or you're referring. So as you can imagine, that whole dynamic is very, very fast moving and fluid. So again, if one thing goes wrong, an account compromised, somebody uses the same password, et cetera, especially with remote work, if, something's compromised, in that manner, that it just really, really is complex. So it's really in getting into that granular level of monitoring that, layering in two-factor authentication, privilege access management, and really just making sure you're minimizing the impact of that. And then again, partnering with the privacy team to really make sure that people are looking at what they're supposed to in more of a proactive manner. So there's a lot of pieces that go into that, that again, user anomalous activity is something that I've always put in as part of that second precursor, to make sure that if people are doing activity from somewhere they typically don't, building some of these rules out to go out there and shut off active SIS. You never want to do that in a healthcare setting, but if it's something that looks like, Dr. Ramirez typically never goes to the system and he's an ED doc, why would he be logging in from Russia or Florida, out of the blue? So some, really just baseline stuff on access information that can really help drive stopping a lot of that information. But it is very, very complex. And there's a lot of great technologies out there, but technology alone won't fix the issue. So it's looking at, your people, understanding what they're doing within the organization, the people to manage that and understand your organization, process and procedure associated with that, how you onboard, offboard people into your organization based off of what they're doing. We're seeing third-party risk management. Again, I mentioned that earlier. So vendor access, what are they accessing within our system? What do they need to do? Do they need an unlimited kind of access? How are we granting that access? And then offboarding. So there's a lot of good complementary then technologies to not only automate that, but if you're automating that, that's trusting the machine and or AI to do a lot of this for you. So there's a potential for giving wrong access, et cetera. So that really drives security assurance, making sure that if you automate, you're putting a process procedure, you're putting a policy together, that you really are aligning that assurance practice to make sure that you're practicing what you preach and not putting your organization at risk.
Wow, there is so much there in what you just said. It's unbelievable. It's interesting at a high level, the philosophy that we're talking about, both for identity and access management and for something like network segmentation. It's all about shrinking the vulnerability. So somebody gets in through a phishing attempt, and because you have your access management, tight, they can't do that much damage. Somebody breaks into a medical device because the underlying operating system can no longer be patched. They're not putting out patches anymore. It's obsolete, but the device still works and it's worth a lot of money, and we're not going to get rid of it. They get it through there. If you've got that segmented, we've minimized the damage they can do. It's all about, they're going to get in. How much can they do once they get in? And to your point, the detection, I want to know when they're in as soon as possible and deal with it. So all these things work together, and I suppose they all fall under the zero trust umbrella.
Correct. And it's about inconveniencing a threat actor to the point that they want to do that, and or limiting the damage. I love to use the use case, especially around the holiday season, of Kevin McAllister and Home Alone. The wet bandits, or the threat actors, are trying to get in. He puts different traps and things into place to really keep them out. Do they still get in? Yeah, they do. But as you saw, in a kind of a humorous way, that they put a lot of traps externally, being your perimeter, to try to keep them out. And then once they're actually in your house, being inside your systems, and that in that manner, that there's also other traps to better protect and or inconvenience them, all while you're hoping that then the police will show up, your incident responders, to be able to, mitigate and get things back to normal. So just another way to kind of normalize it with, a real life example, to kind of make it fun in a sense. So
It's interesting. You mentioned, we talked about IAM is hard. It's not easy. It's a lot of work. It's very intensive. And it's the same thing with network segmentation, right? It works, but it's hard. It's not easy. It's intensive, correct?
correct. It's expensive. It takes a lot of man hours. It takes a lot of architecture design, and there's also limitations. So if I was building a new hospital tomorrow, this would be different, as you're being able to build everything net new. But as you can imagine, you can't just halt all operations in a hospital as is. We have legacy devices, there's hardware refreshes, we've got hosted systems. So again, that's why healthcare is such an easier target than some of these other systems, because they're able to harden their systems, harden their perimeter. But our attack surface is just so much more wide and expansive on what you're able to go, just because we have medical devices, we have IoTs, we have people coming in a children's hospital where we have Xboxes, because you want kids to be able to do stuff while they're getting treatment. So as you can imagine, those intricacies and complexities also drive additional risks that we have to look at from those lens of access, segmentation, early detection, etc. Is this a friend or a foe? So that's almost a 24/7 job, making sure that you're able to normalize that, and then a new risk can be introduced, a new technology or a log J4 of a 0-day, and then it's something else popping in. So
Yeah, it's interesting. I mean, I would imagine this has happened before, but it sounds so unique, the sort of the regulatory dynamic that health systems have, specifically CIOs and CISOs have to operate under. You're being told at the same time that you must protect everything, and yet you must allow all data to be fluid and move and exchange and give it to who wants it. At the same time, you're being told those two things. You'll get your hand slapped if you don't open up, and you'll get your hand slapped if the wrong people get the data.
correct. It is a robbing Peter to pay Paul sometimes on that. So
Yeah, challenging.
yes,
Let's as we mentioned before, you're now working with my good friend Chuck Podesta as the CIO over at Renown. So tell me a little bit about what you think are the key to CISO CIO relationships. I assume you report to Chuck,
yes.
and we see that a lot. That seems to be sort of the predominant structure. CISOs reporting to CIOs. There are some exceptions, here and there it's done a little differently. But what do you think is the key to that relationships in terms of what do you need? If you are reporting to the CIO, what does the CISO need from that person to be successful?
Really to understand the broader digital strategy and different work streams. Because again, I personally I know there's always been the debate about where the CISO reports. I have a dotted line to our chief compliance officer as well. But that discussion has been going. I don't think if a CISO isn't part of IT that they will get as much truth and have a pulse on all the technology risk as much as they would if they weren't. I think that's still part of strong partnerships and relationships. But a good CIO like Chuck, very security conscious, and I've been lucky to have two great CIOs that I've worked for, between U of L Health and Chuck. That again, yeah, just having that level of trust, having that they know you're here to protect them as well. Because if the CEO is going to call them first if a system's not working, not understanding if it's XYZ, and they're also the key leader of all things technology within the hospital. We always say all things that go beep is owned by the CIO. So as my job is to protect all things that go beep. So it's really having that partnership on what your vision is, what their roadmap looks like, and then aligning that, because security is part of it's everybody's job in the organization, not just from a technology standpoint. So it's really being that supplemental service to align to what the CIO's direction is, pushing innovation, looking at research, looking at all those integral discussions that they're embedding in with the business to then see how can we protect that from that access detection, those data sets, ensuring data movement, all of those components that you've talked about that enable that quality, safe care. So it's again, building that level of trust, building that, great relationship. And I think that all CIOs this day and age, really understand the importance of the CISO and their role to support them and protect the assets. And I think that relationship's gotten closer over the past, 3 to 4 years when we've seen the onset of ransomware. But it's been, if you have to educate your CIO on security, then, at this day and age, it's pretty crazy. But again, there is so much, that whole ecosystem I spoke to, the CIO owning that. I think that they understand really the importance of being proactive instead of reactive on a lot of that, and just, intertwining that on, and then them supporting you on that too. That, again, having your CISO a lot, again, this day and age, most people are going to, come to the table and not push back too much on that, but supporting that, and then having, the rest of the chiefs as well, saying that if he's saying this is a risk, we need to push back. We need to, as a leadership team, understand and support that. So,
Yeah, and what I'm thinking is, those discussions we talked about earlier, as the CISO goes out and tries to shore up the disaster recovery and business continuity from a high-level organization-wide patient safety perspective, the CIO is going to have to support their CISO, because that may be necessary to get some of those conversations going. Does that make sense?
yes, and I agree 100%. So.
Very good. Well, we're about out of time, Steve. Final question. Let me frame this up. You're speaking to someone and a CISO at a comparable sized organization. What's your best nugget piece of wisdom or advice for them as they go about trying to protect their health system?
Don't always say no to the business, because you never know on an act of goodwill when that can come back to be needed down the road. So a lot of times, the security guys are no, never answer any questions, never collaborate. So again, building that relationship with the business, and being, instead of saying no, maybe, to better understand that, where you can compromise on a lot of that our job shouldn't always be no, because we're here to support the business. So to always remember that we're here, again, especially in healthcare, that again, we need to look at process and workflow, and then see how we can compromise, have a mitigating control, and or minimizing access, etc. That's always been my thing. And I think learning from growing up with 2 clinicians in the house, but also seeing just where other CISOs are successful, and really, again, it is that partnership and collaborating with key stakeholders. So
That's perfect, Steve. Thanks so much for joining me today. I think people are going to really enjoy this.
yeah, appreciate it. Thanks for your time.